About brain tumors. I'm Scott Gilbert. Thanks for joining us. Nearly 100,000 brain tumors are diagnosed each year in the United States. That's almost enough people to fill Beaver Stadium up at Penn State. Here to talk with us today about brain tumors and to answer any of your questions are Dr. Jim McInerney and Dr. Heath Mackley. They are both the co-directors of Gamma Knife Radiosurgery program here at the Milton S. Hershey Medical Center. Thanks for being here today, guys. I understand that most brain tumors are malignancies that actually started elsewhere in the body. Can you talk about some of what those most common areas are?
Sure. Cancer can arise from pretty much any part of the body, but for cancers that start somewhere else and go to the brain, the most common would be lung cancer, breast cancer, melanoma.
Now, when we talk about cancer, we often think about benign versus malignant, but Dr. McInerney, I understand that even a benign tumor in the brain can be dangerous. Why is that?
Sure. Well, part of the reason we think a malignant tumor that goes to the brain is bad is because your brain's obviously pretty important, and anything that gets damaged up there is potentially going to affect your life. So a tumor, even though it's benign, even though it's slow growing, could be in a spot where it's going to affect, say, a nerve or other structures that make you incapable of doing something. So it could make you deaf, or it could give you trouble with balance or walking or something like that. So even a tumor that is behaving benignly, growing slowly, doesn't seem like it's that big a deal. If it gets big enough, can become life-changing, and not in a good way.
As we continue our conversation, we welcome your questions for Dr. McInerney and Dr. Mackley. You can just add a comment to the comment field below this Facebook post, and we'll pose that question to them live. If you're watching this video on playback, feel free to still pose your question, and we'll get an answer for you as well. What do we know about the causes of brain cancer? And for that matter, what do we not know?
Well, there's a few things we do know, and then there's things that we're still working on. So one of them is environmental exposures. We do know that radiation exposure can lead to the creation of brain tumors, especially meningiomas. We also know about specific hereditary disorders that are tied to certain genes. So we know there are certain groups of people where in their family certain brain tumors run. And what we've really been learning a lot about more recently over the past decade is most people don't have brain tumors in their family. It's not an identified hereditary disorder. Instead, it's a series of genetic errors that ultimately leads to the brain tumor. We're really starting to learn all of those steps, and hopefully that will lead to targeted therapies that go after those genetic mutations.
And Dr. McInerney, what are some symptoms of a possible brain tumor? Keeping in mind that if you have one or two of these symptoms, it doesn't necessarily mean a sure diagnosis.
Sure, and that's probably the thing. Everybody always says, I have a headache, I must have a brain tumor. And obviously, most of the time, headaches are not. But the way I like to characterize it is if you have a really bad headache, like the worst headache of your life, or a headache that's not going away and keeps staying around, the headache that comes and stays rather than the headache that comes and goes. If you have a neurological problem with that headache, your eye is drooping, or you can't hear, or you're weak or off balance or something like that. If you have a seizure, so a neurologically cursed headache, those are the kinds of headaches that we worry more about. So the one that comes and stays, the one that causes other problems. And all of those other problems obviously can happen without a headache too. And so when people have neurological problems, specific things that aren't working right, especially focal things, not just I don't feel right, but I can't hear well, I can't walk right. Those are the kinds of things that really make us sit up and take notice.
So not a headache for a day or two. It goes a little beyond that.
Right, exactly.
You're watching Ask Us Anything About Brain Tumors from Penn State Health. I'm Scott Gilbert alongside Dr. Mackley and Dr. McInerney. Feel free to let us know if you have any questions. Just post them in the comment field below this Facebook post. And also we ask you to, if you're enjoying this video, you're finding it informative, please share it as well on your Facebook page and help to get the word out about this good information. I'd like to ask you a little bit about how brain tumors are diagnosed, including how you determine whether it's malignant or benign. How does that process begin?
Sure. Well, there's generally two things you can do. The first one is you get imaging. And so often that's an MRI. Occasionally it's just CT scans instead, because there are people that cannot have MRIs. And then the other second thing is usually getting a biopsy. Now, there are times when we will occasionally not do a biopsy because it's either a very bad location or we are almost certain it's a benign tumor based on how it looks in the MRI. But for most people, it's imaging and biopsy. Those are the two ways that we figure out exactly what kind of brain tumor it is.
We all know the brain does a lot of different things. There are many different parts to it. So I imagine part of the severity of a diagnosis, I would imagine, depends on where that tumor is located, correct?
Sure, absolutely. And there are, all different types of tumors that can give you all different types of problems, obviously. A lot of the benign tumors that we see will often, like I said before, give sort of focal problems where all of a sudden you can't hear, or your balance is off, or your vision is off, or something like that. There are other tumors that can be more diffuse, and they can attack larger areas of the brain. And so people have trouble thinking or, planning or participating and things like that. So there's a lot of different, kinds of symptoms that you can have.
A lot of different treatments too. Chemo, surgery, radiation are all options. So how do you determine the best treatment plan for a particular patient? Where do you start?
Well, it starts with a team. And so besides seeing the individual physicians, the physicians will get together into a meeting called a tumor board. So we'll have neurosurgeons there, radiation oncologists, neuro-oncologists, radiologists, and we'll all put our heads together to say, for this individual patient, what's the best plan of care for them?
Dr. McInerney? Sure. One of the things you need to know is what are you taking care of, right? And there, as we've said, there are an awful lot of different types of tumors and problems. Some things are going to be, again, very focal in one location. If it's something that we can identify and take out, we love to be able to operate on something and make it go away forever. But there are other things where that's not possible. There are some tumors where they are diffusely growing within normal brain cells that are doing important jobs, and we can't just cut them out and make them go away. And so in those situations, sometimes we have to do something that's going to target those bad cells without hurting the good ones as best as we can. And that's where things like radiation and chemotherapy come into play. And so obviously knowing what you're dealing with is what you have to start with anytime you're trying to make these kinds of judgment calls and decisions.
And the most targeted type of radiation is gamma knife radiosurgery. We've been doing that here in Hershey for many years, but just recently upgraded to the gamma knife Icon. So let's talk a little bit about that machine, which is just down the hall from us right here where we're standing. So when does that come into play?
So anytime we're treating, it's maybe a little bit off from what I just said, but when we're treating something focally, but we're trying not to do a traditional operation. Right, so we can target anything in the brain with radiosurgery, and the difference is basically that when we do radiosurgery, we sort of mean that as we're going to do it once, or maybe occasionally we'll divide that up into 2 or 3 treatments. But for the most part, we're trying to do a one-time radiation treatment to obliterate, to kill whatever it is that's causing the trouble. And so there are a lot of different tumors and other conditions, too, that we can target that way.
And tell me how that works. I mean, how are you able to target a part of the brain in such a non-invasive way? I guess it all involves a lot of beams of radiation that basically meet in one place, right?
Exactly. So it's sort of I like to think of it as a geometric solution, right? The trick with radiation is how do you hurt the thing that you want to hurt and not hurt everything else. And with the gamma knife, we take 192 low-dose beams and point them at the same spot. And so that each individual beam is not powerful enough to really be damaging, but where they come together, that energy summates and increases exponentially. And so what we target, what we put at the focal point where all of those beams are meeting, gets damaged. But as we get away from that central point, that dose of radiation goes down exponentially, so that even though everything sees radiation, doesn't see enough to be damaged by it. We see radiation when we walk outside, sure. And we don't get damaged by it. So you see radiation all the time, and that's what we have to do is to make sure that everything that's normal that we don't want to be damaged by this doesn't get enough radiation to be damaged by it. We want to hurt the thing that we want to target, the tumor or whatever else that we're going to put there.
Makes good sense.
I think it's important to add with the actual planning process that it's a team approach as well. So you have a neurosurgeon and a radiation oncologist develop the plan together, and then at that point a medical physicist will then review the plan to make sure that all of the safety and quality parameters have been achieved. So it's really a team effort also in creating an individual plan for each patient.
A lot of people behind each of those procedures.
Yes.
And tell me a bit about the importance of the recent upgrade to Icon. Why is that an important step?
Well, I'm really excited about the Icon, and that's because it takes the strength of the Gamma knife, which Jim just described very well, but it adds a few things that gives us a few more capabilities. And so one thing we're able to do now is to treat with a mask instead of a framed system. Now, we still use the frame system a lot. It's a very good system, but there are patients that can't have a frame, and the mask gives us an alternative for those patients. Additionally, the mask system allows us to treat patients in more than one treatment. Jim had also alluded to that. There are patients where there is an advantage to treating 2, 3, up to 5 times, and it's generally patients that have tumors that were too big for a traditional single treatment Gamma knife. So the mask allows us to do that. Besides that, we also have a motion management system, because the mask isn't quite as tight as a frame is. However, we're still able to individualize the plan for the patient, because we will do a motion study to see exactly how much the patient moves during the time that they're laying under the mask, and then we can take that into account in our planning process, so that way we don't miss the target at all. And then the last thing is we have a cone beam CT, which gives us a lot of flexibility. For the people that don't know what that means, basically we're able to get a mini CT scan while the patient's on the table right before we treat them. That is a quality assurance check for patients with frames, but it also gives us the flexibility of being able to plan off of MRIs that weren't done that day.
So it really allows you to be as precise as possible. All that's
Yes.
what it really amounts to. Great. Well, thank you for the good information. And if you have any questions, even if you're watching this video on playback, we encourage you to share them in the comment field. We'll track these guys down and get an answer for you. And we also encourage you to share this video as well to get the word out about this information about brain tumors. This has been Ask Us Anything About Brain Tumors from Penn State Health. My thanks to Dr. Jim McInerney, Dr. Heath Mackley, and my thanks to you as well for tuning in.